Hey, hey class, actually. I'm driving today. So I'm recording this for our class for you it's tomorrow because the 26th of June is when you'll be viewing this, or available at least for you to view. But I'm making this because not only because I have a long commute, I got accepted to I got a new job. I'll be managing UCLA sleep lab, so it's a long commute for me. But I want you all to get this video because I want to address the ventilation part, or the titration portion of the RPSGT exam. Some of the questions will be on the advanced modes, and that's why I want to make sure that you guys are comfortable with it. So without further ado, this class I will talk some of the basics so that the other intro to fundamentals of polysomnography students can also benefit, but I will go deeper into the advanced titrations and explain things. Aside from that, I'll try to see if I can highlight some of the possible questions on the examinations. So sorry if there's no PowerPoint, but it's probably better in a way because you can just listen to this video instead of watching it. So you can listen to it while you're at work, on a break, etc. All right, let's begin. So I'll start at 1 minute 50 seconds. When it comes to titration, you have a few modalities. The majority of your titration will be on CPAP. So all of you, if not majority of you, are respiratory therapists. So you are very familiar with the CPAP and other modes on mechanical ventilation. However, when you titrate in sleep, remember that this is a leak type of titration. There is leak, and so it's not like mechanical ventilation where you also measure the exhalation expiratory phase of the patient and properly calculate the patient's volumes, right? This is all calculation. All right, on that note, there will be differences, but on CPAP, let's start with CPAP titration. When the patient comes in for CPAP titration, it's because their main possible diagnosis or established diagnosis is obstructive sleep apnea. Okay, we don't apply CPAP to any other diagnosis such as primary snoring. No, because that's not accepted as a diagnosis. So you have to remember when you take the examination for RPSGT, or you are working for a company in or outside of the Philippines and other countries, this will be true. This will still be the correct assessment and information or guideline. Okay, CPAP titration are for those patients who suffer from obstructive sleep apnea, not for primary snoring, because the insurance companies will not pay for it. I know that in other countries people pay cash, but we're talking about particularly you guys that are about to take the RPSGT exam. I want you to have that frame of mind. I want you to think that you work in the United States because you are going to get the RPSGT licensure. So you cannot think like you still are in the Philippines or the Middle East or UAE or Australia. You have to think as if you are in the United States. Okay? So here in the United States, sleep apnea, the study, the titration, home sleep, the supplies, everything is paid for by the insurance companies. Do the patients pay? Yes, they do. They pay a premium, right? It's called a premium. They also pay a copay. So the copays vary. It depends on what kind of insurance they get. Whether they get something really, really good and expensive, such as the private insurance or PPO, or something cheaper like the HMO, right? It's managed care type of insurance, or the government insurance called the CMS, or Centers for Medicare and Medicaid. So remember these terms: Centers for Medicare and Medicaid. That's the government insurance, very similar to the Philippines PhilHealth. Okay. On that note, the rate of payment for these devices, for these titrations, for these studies also vary based on the type of insurance. Okay, so let's put that back. Let's put that on the side. Actually, now you come in as a tech. Your patients now are diagnosed or are about to be diagnosed with obstructive sleep apnea. That means you're going to titrate with CPAP. Okay. Now, with CPAP, the only way you go is upwards, right? You start at 4 or 5. It's acceptable. You can start at 4 centimeters or 5 centimeters of water pressure. It depends on the doctor's orders. If the doctor, the referring doctor, does not specify for you to start at 5 or 4, then start with your clinical call. You can decide whether you start at 4 or 5. Okay, but for the most part, patients who are new to therapy or has never done any type of titration, then you start very low. Okay, you can stay very conservative, meaning to say start at 4. Okay, but there are instances where you need to start higher than 4. So what are those instances? One is if the patient has been diagnosed with apnea and they have a pretty severe case. Okay, 2, they are bigger people, heavy set, maybe with a high BMI. Okay, but for me, the height matters more than the width. Okay, because the patients who are very small and then big with high BMI, they might be uncomfortable when you start a little too high, like 5 or 6. Okay, so smaller people typically start with small. The lowest pressure setting for CPAP is 4. Okay, there's no lower than that. In fact, the settings for CPAP, when you're asked in the exam, what is the range for pressure of CPAP, is 4 to 20. Range for APAP, 4 to 20. Okay, now range for bilevel or BiPAP, then you start at 4 on EPAP, but you can go as high as 25 on IPAP. There are other bilevel devices that can go as high as 30 on IPAP or up to 40. And then you just deduct 4 centimeters of water pressure. That will be also the lowest EPAP setting. Okay? Now on that note, you will be titrating on CPAP primarily. The only way you will switch to bilevel are at least two reasons. One is if you are titrating at on CPAP mode and the patient continues to have apneas at a pressure of 15 centimeters of water pressure, then instead of going to 16 centimeters or 17 centimeters of water pressure, you can switch to bilevel. So you can go to 15 over 11, or you can go from 19 over 15, or you can restart at 8 over 4 on bilevel. And you justify by annotating that the patient continues to have persistent sleep apnea at a level of 15 centimeters of water pressure on CPAP mode. So that's acceptable. That's actually a test question on the RPSGT exam. The other reason how you can go from CPAP to bilevel is with the patient discomfort. If the patient says, I can't tolerate this, and you are barely at 10, 11, or 12 centimeters of water pressure, you can already switch to bilevel. Even when you just first start CPAP at 5 or 6 and the patient says, oh, this is too much, so you can annotate that the patient is having difficulty exhaling out, if that is the patient's complaint. And then you can switch them to bilevel, because that pressure relief when they exhale might be more comfortable for them. And so that's the second reason how you can switch from a CPAP to bilevel mode, and that the insurance will still pay for it. Okay, you can't just willy-nilly replace CPAP order to bilevel without any justification. Otherwise, that study will be nullified. It will not be paid for by the insurance company. Remember that. Now, on bilevel, there are questions about, well, you're coming from CPAP of 15. Do you go 15 and then add a pressure support so you'll end up with 19 over 15? Or do you go 15, CPAP of 15, then you make that 15 as your IPAP and you go EPAP with 11, right? So there are different case scenarios. However, it will also be based on your clinical judgment. You have to, you as the tech have assessed these patients. You are working with these patients all night, so you have more ability to make a decision on what would the patient tolerate better. Okay, we'll discuss and look at the actual look at the actual policy or guideline for titration, and then we can then discuss further about this issue on how to switch from CPAP to bilevel. Now, on bilevel mode, right? Bilevel mode, they are accepted to be used for obstructive sleep apnea patients, and then OSA patients that are not compliant with CPAP or intolerant of CPAP mode. So they can be used. And then you have the other types of patients that are better off with bilevel, such as your COPD patients, your neuromuscular patients, okay, especially if they're just newly diagnosed, they are better off on bilevel. Now, some of these patients will require a backup rate eventually. So you will go from spontaneous mode, which is a bilevel without a backup rate, to spontaneous time mode, a bilevel with a backup rate. And the reason why you will use a backup rate is when they start to have more central events. Okay. However, the rule of thumb is you will add a backup rate if the central starts to emerge, but not as high as more than 50% of the events. Okay, so they might have events, but they might be predominantly obstructive and not central. If they have central, then you're okay to use a backup rate as long as they don't go beyond 50% of the events. And the central index should not be more than 5 per hour. Because if the central apnea index is more than 5 per hour, that means this patient might be better off with an ASV titration. ASV titration is your adaptive servo ventilation or adaptive servoventilator device. And so on that note, we will discuss further on the central apnea index or central apnea patients that will require ASV, because that's now a step up from the ST mode. Okay, this is very brief, but hopefully it helps. And then we'll go further with additional discussions. Thank you for your attention.